Hello, I'm Mark Gurnell and I'm based in Cambridge. And the topic of this talk today is how I interpret endocrine tests. We're going to look at this through a series of interactive case studies. So I have no relevant disclosures for this talk. So endocrinology, more than anything else, relies on a very structured approach to diagnosis, investigation, and management. So the ideal diagnostic and management pathway is perhaps illustrated by this patient who has clinical features that suggest acromegaly. We then go on to use very well-validated tests, in this case, an oral glucose tolerance test showing a paradoxical rise in growth hormone and also the typically elevated IGF-1 that confirms a diagnosis and allows us to then move forward to further investigation, in this case, pituitary imaging, which shows a large macroadenoma, before moving on to appropriate treatment, in this case, transsphenoidal surgery. But unfortunately, this pathway can be perturbed sometimes by unusual findings in the results of our investigations. And if we're not careful here, this can lead to inappropriate further investigation and or indeed treatment. Now, I'll refer you to another talk in this series, which highlights potential issues when managing patients with thyroid conditions. And this particular figure highlights how one's systematic approach, when one finds unusual results, involve the reevaluation of a clinical history, reassessing thyroid status, and then deciding which of your results is abnormal, and speaking to your laboratory to actually then look for potential assay interference, for example, before investigating for rare genetic and acquired disorders. But I'm not going to go into this in any more detail today, because I say this is actually covered extensively in one of the other talks in this series. Instead, I'm going to use a series of case studies in different areas of endocrinology to illustrate potential pitfalls. I'm going to begin with a case of a 25-year-old man who was referred to a clinic from the cystic fibrosis service locally. As part of routine surveillance, they'd been monitoring gonadal function, and they'd noticed that he had a markedly raised serum testosterone level and asked us whether we could advise on further investigation. So he had confirmed cystic fibrosis. He was homozygous for this specific mutation or deletion. And he had, in his past history, note that he was colonized with Pseudomonas aeruginosa, not that unusual, of course, in this clinical context, but otherwise reasonably fit and well, but a rather extensive medication list compatible with his cystic fibrosis and complications. Now, on examination, relevant to the findings we're going to see, he was an otherwise normally virilized man. There was no facial plethora, acne, no gynecomastia, normal cardiovascular, respiratory, and abdominal examinations, including testes, which perhaps just towards the smaller end of the reference range for an adult male of 15 to 20 mils bilaterally, but with no palpable masses. But herein lies the problem. So all the results that you will see during the course of this talk will show the parameter that's being measured, the relevant reference range, and any values which are normal will be shown in gray. Anything that is in red shows an elevated result. Anything which is in blue shows a low result. So here we can see that the serum testosterone level is really quite markedly elevated. And when this sample is repeated, it is still markedly elevated. In fact, it's above the upper limit of reporting for the reference range without a dilution. But the LH and FSH, so the two pituitary hormones, of course, are comfortably within their respective reference ranges. So we have a markedly elevated serum testosterone level, but without suppression of LH and FSH. So I think it's interesting just to pause and think for a moment about what the potential diagnoses here might be. And in particular, what's the most likely explanation for the raised serum testosterone level in this patient? Is it an artifactual result? Does it signify perhaps somebody who is taking anabolic steroids? Could this be due to a Leydig cell tumor of the testis? Is this actually central in origin? So there is a pituitary gonadotrophinoma with excess secretion, for example, of LH causing the high testosterone? Or is this an artifact, for example, with raised SHBG level secondary to liver disease causing a raised elevated total serum testosterone? And just to remind you of the mechanism for this, testosterone circulates bound to a number of binding proteins, the highest affinity one being SHBG, sex hormone binding globulin, but there's also again binding to other proteins, for example, albumin. And in actual fact, as we're going to see, this is actually an artifactual result. And this just goes to show that we need to have a high index of clinical suspicion. because when this patient was initially referred to us, the main concern was that this might be anabolic steroid use. But the result, which is really unusual for that, will be the detectable measurable gonadotrophins, the LH and FSH, which we normally would expect to be suppressed by this degree of anabolic steroid use, such that we're raising serum testosterone level to considerably above the reference range. So instead, in a patient who has no features of excess androgens, either clinically or, for example, other surrogate indices such as a raised hematocrit or hemoglobin, we were suspicious about the fact that this might be an erroneous result. And in fact, this is the same blood sample sent through various laboratories. One platform is revealing a value which is heading towards the lower end of the reference range, a mass spectrometry measured result which is actually comfortably within the reference range, another immunoassay now starting to show a value towards the upper end, even higher in the upper end of the reference range, and then the original assay which generated the high results. There's no way in which this can be a true reading because it's the same single blood sample aliquoted and sent to multiple laboratories. And in fact, this turns out to be significant laboratory assay interference. And the true result here is the normal serum testosterone level of 14.1 nanomoles per liter. And as you can see, each of the assays is probably suffering differing degrees of interference, perhaps with the exception here of the Beckman platform, where that result is potentially compatible with the mass spec result. And so this really allows me to highlight one of the approaches that I take to patients who have unanticipated results. Whenever that's found, either be an endocrine laboratory result or a radiology finding, I would strongly encourage you to go back to the patient and review the clinical context. Where there is a possibility that one of the laboratory results is incorrect, or it is certainly not in keeping with the classical disorder associated with a high hormone or a low hormone level, then going back to the patient and determining whether the symptoms and signs fit with one or the other is absolutely crucial. And only when you've done that should you decide whether you need to judiciously use additional laboratory tests or indeed additional radiology in order to be able to disentangle and work out which of the results is the abnormal result. So in this particular case, going back and seeing that the patient was not demonstrating any features of either hypo or indeed hypergonadism, as it were, allowed us to determine that actually it was likely to be the testosterone result, which was the incorrect result here, which then allowed for further laboratory analysis to identify assay interference. So let's now move to a different field, which is the adrenal field, and highlight some other important lessons. So here I'm going to talk about a 30-year-old lady with a history of high blood pressure and hypokalemia, and her primary care physician had quite rightly questioned whether she had Conn syndrome, or perhaps now more appropriately referred to as primary aldosteronism. This is a lady with hypertension for many years and unprovoked hypokalemia, so this feels very suspiciously like primary hyperaldosteronism. Nothing else of note, and at the time that she was referred on, she was actually on doxazosine and potassium supplements, which she was taking daily in order to maintain a low normal serum potassium level. The examination was relatively unremarkable, and her blood pressure was still not optimally controlled, with 143/96 millimeters of mercury seated. So there are the initial measurements and the initial medications, and the screening biochemistry for primary aldosteronism involved measurement of plasma reading concentration, which, as you can see, is undetectable, with a high plasma aldosterone concentration and therefore generating an extremely high aldosterone reading ratio. So at this point, what would you think of as the most appropriate investigation to confirm primary aldosteronism? Would you do a captopril suppression test, a fludrocortisone suppression test, an oral salt loading test? Do you think no further investigation is required, or would you do a seated saline infusion test? So again, this just gives you a chance to have a think about what you might consider doing next. Well, in actual fact, no further investigation is required. And I think the important point about this case is that it's always easy to order additional tests, but we need to be very careful about doing them when we might not need them. And the reason we don't need to do another test here is captured nicely in the Endocrine Society's guidelines, which clearly say that in the setting of spontaneous hypokalemia, which this patient had, plasma reading below detection levels, which this patient also has, with an aldosterone concentration in excess of 29 grams per deciliter, or here greater than 550 picomoles per liter, then there may be no need for further confirmatory testing. And in fact, in many patients, this is very much the case. So here we don't want to do additional tests, which is just going to slow things down if we don't need to do them. So we appear to have a patient with a diagnosis of primary aldosteronism. And when we go on to perform imaging, we can see that there is a sizable lesion in the right adrenal gland, where I'm just showing with my cursor here, with a relatively normal looking left adrenal gland, and hopefully highlighted by those arrows. So the next question, which is the most appropriate next lateralizing investigation in this patient? Do we need to proceed to adrenal vein sampling? Should we be doing an MR scan of the adrenals to look at the anatomy in more detail? Should we be performing some form of scintigraphy, for example, NP59 scintigraphy? Is no further investigation required at this stage? Or should we engage in PET-CT imaging work that we have done here in Cambridge, looking at the use of a particular radiotracer 11C metomidate, which allows for localization rather than just simple lateralization of the adenomas or nodules that cause primary aldosteronism, and is therefore an alternative to AVS. The question is, what would you do next or recommend for this patient? And of course, it may well be dictated by the availability of services local to you, because very few places at this stage, for example, have access to PET-CT. But in actual fact, again, I would contend that no further investigation is required, because further investigation may be unnecessary. And again, referring to the Endocrine Society guidelines, it clearly states that in younger patients, as this patient was at the time of diagnosis, with spontaneous hypokalemia, marked aldosterone excess, a unilateral adrenal lesion that is consistent with an adenoma, which this was, then you may not need AVS before proceeding to unilateral adrenalectomy. And this is really important, because in actual fact, this patient was referred from another center where that guidance was not considered. And in fact, this patient went on to have adrenal vein sampling. And we can see that actually, looking at the cannulations shown as a selectivity index, there's no doubt that the catheters were inside the right and left adrenal veins. But rather dramatically, there was no gradient between the right and left, and indeed the aldosterone to cortisol ratios, despite good catheterization, were lower in the right and left adrenals than they were in the IVC. So this really emphasizes the point that here an investigation is being done which is unnecessary, and in actual fact has now confused the situation, because it hasn't clearly shown that despite a large lesion on the right adrenal, that this patient has a unilateral cause on the right-hand side. And this is recognized and has been reported by Michael Stowasser and colleagues as occurring in not an insignificant number of AVSs. Now, I did mention that PET-CT is another alternative here, and in actual fact, because we had this available locally, we were able to demonstrate very hot uptake of the radiotracer in the right-sided lesion rather than the left. And in fact, the patient went on to have a unilateral right adrenalectomy, which resulted in complete clinical remission and also biochemical remission, confirming that in actual fact, the patient did have unilateral primary aldosteronism. The point here is that we can always order more tests, but we might not always need those tests, and they might confound our interpretation of results. So I'm just going to stay with primary aldosteronism for a minute, again, to show where we need to be quite astute when managing cases for potential pitfalls. So here's a 70-year-old gentleman with hypertension, with spontaneous hypokalemia, on multiple agents to control his blood pressure. Now, he had good washout of confounding medications before he went to measurement of aldosterone and renin. And so although amlodipine is still in the equation and potentially can suppress plasma aldosterone concentration, once the beta blocker was gone and the plasma renin was now measured clean, that was clearly suppressed in plasma renin activity assay. And with the plasma aldosterone concentration above 550 and spontaneous hypokalemia, he meets the diagnosis for primary aldosteronism. He also has a lesion on both adrenals, small lesions on each side. However, there was another confounder, because his blood test had been repeated, and this time samples sent to a different laboratory using a mass assay actually indicated that he didn't have primary aldosteronism. Because although he had this history of hypokalemia and had confirmation of raised aldosterone concentration, here, using plasma renin concentration rather than plasma renin activity, the renin is clearly not just measurable, but actually towards the upper end of the reference range. So now we have a conundrum, because we have a patient who appears to have primary aldosteronism based on difficult to control hypertension, history of hypokalemia, previously suppressed renin activity, and a raised aldosterone concentration, but now with a diagnosis which appears to have disappeared. The question is, does this patient have PA or not? Or does this patient actually have renin-dependent hyperaldosteronism? Well, in actual fact, when we repeated a further sample, and this time sent blood both for renin concentration and activity measurement at the same time from the same blood sample, you can see that the activity assay and the concentration mass assay truly return very divergent results, with a ratio which is either strongly suggestive of PA or not suggestive of PA. So the same question, does this patient have PA? But in actual fact, this patient has got assay interference in the mass or concentration assay, very similar to the scenario that can occur in patients with TSH laboratory assay interference. So when this patient's blood sample for mass measurement was 1:1 compared to controls, and then subject to a 1:2 dilution compared to controls, whilst the controls back multiplied to values which were relatively comparable to the neat sample, you can see there was a near halving of the value in the patient here. And this patient appears to have interference in the renin mass assay or the concentration assay, which is producing an artificially elevated renin result, but the activity assay, which is really telling us about the biologically active renin that's there, actually returns the true result here. So the message here is, if it looks like, it smells like, it tastes like, if you like, primary aldosteronism, just because one result is not sitting comfortably with it, you shouldn't just automatically assume that. You need to do more detective work. And there are various reasons why we might get a false negative ARR screen. This is just one of these reasons shown here at the bottom. But we also need to remember it's important to correct hypokalemia. It's important not to sodium restrict the patient, because that can cause desuppression of plasma renin. Think about the use of calcium channel blockers. It didn't cause a problem in this case, but sometimes it can suppress the aldosterone so far that actually you cannot see the diagnosis. Also think about medications that desuppress the plasma renin, but equally, of course, if you find a low plasma renin on these medications, that is highly suggestive of the underlying diagnosis. Don't forget to the potential for concomitant malignant or renovascular hypertension. So the plasma renin is not suppressed here. And then spontaneous fluctuations in aldosterone secretion, which we're not going to talk about in any detail today. I'm just going to move on now to pituitary disease, and also just use again an illustrative case with potential catches to show why it's really important that we're on our toes and always reappraising the situation. This was a young lady referred to me who'd been found to have a pituitary microadenoma on an MRI scan for headaches. But when things were tied together, it was thought that possibly the fact that she was overweight with irregular menses could indicate underlying Cushing's syndrome, which of course in a young lady of this age would likely indicate Cushing's disease. Primary care physician had already done an overnight dexamethasone suppression test, which was abnormal, not suppressed, as you can see, 112 nanomoles per litre. And we were asked to see for further investigation. So she had this long-standing history of struggling to maintain normal body weight, a history of oligomenorrhea with 3 to 4 cycles per year prior to commencing the combined oral contraceptive pill, which had now normalized things. There was no other past medical history of note, and her only medication was indeed that combined estrogen-progesterone contraceptive preparation. On examination, she was indeed overweight, BMI 28.5 kilograms per meter squared, and blood pressure was towards the upper end of what one would expect, obviously, in a young lady, 140/85 millimeters of mercury. There was mild facial hirsutism, but no plethora, no thinning of the skin or excess bruising, no proximal myopathy, and she had normal visual acuities and fields, which were obviously in keeping with the presence of a microadenoma. There is the overnight dexamethasone suppression test result. And she also had a urinary free cortisol result returned to the laboratory. And you can see versus a reference range of less than 180 nanomoles per 24 hours, this was raised at 245 with a urine volume of 5.2 litres. So now you've seen that result with the clinical index of suspicion and the results that we have so far. What would you do next? Would you proceed to a high-dose dexamethasone suppression test? Would you undertake inferior petrosal sinus sampling? Would you measure late night salivary cortisol levels? Would you undertake a low-dose dexamethasone suppression test, or do you think the plasma ACTH is the next measurement? And of course, again, some of the views on the next investigation here may be determined by local availability. Well, actually, what I would strongly advise in this situation is that we don't start jumping too far ahead of ourselves and actually trying to identify the cause of this patient's Cushing's syndrome, because I would contend that at this point in time, we have yet to prove that this patient has Cushing's syndrome. And so the correct answer here is actually to use another investigation to determine whether the patient does or does not have Cushing's. And here I would suggest late night salivary cortisol. So this is taken from now quite old Endocrine Society guidelines, just suggesting the approach that we might want to take in a patient with suspected Cushing's syndrome. And that's obviously assuming that we've excluded exogenous glucocorticoid exposure. And really, there are three different sets of tests which still remain the mainstay today. Urinary free cortisol collections, at which point we need to have at least 2 24-hour urine collections, and probably the more the better. Dexamethasone suppression testing, typically done using the 1 milligram overnight test, but there are many variations of this, including the 2 milligram overnight test, or indeed using a 48-hour low-dose classical suppression test, or late-night salivary cortisols, again, using at least 2 collections. And if all those results, or sorry, whichever result you use is normal, then probably Cushing's syndrome is less likely, but abnormal results generally need further investigation. So we're here back at this stage, I would contend, with this patient. And again, my approach to the interpretation of the results is to go back and say, what is the probability that the patient has the condition that I'm investigating for? And in Cushing's, I think it's always useful to categorize one of 3 ways. Does the patient have a low index of suspicion of Cushing's, an intermediate index of suspicion, or a high index of suspicion? The reason that's important, because I think that it's reasonable if you do not think the patient has Cushing's and you simply want a single rule-out test to use just one. But the minute that you feel clinically that there's either an intermediate or a high probability of Cushing's, then probably you're now looking at 2 tests to be concordant, or even more, repeated if necessary. And in this potential case, there was a significant confounder. So when we perform a dexamethasone suppression test, we need to bear in mind potential false positives, or indeed false negatives. And false positive cause of dexamethasone suppression, maybe the patient has a Cushing's-like phenotype, but doesn't have Cushing's, for example, due to non-tumoral hypercortisolism, often referred to historically as pseudo-Cushing's syndrome. Could be the patient hasn't actually taken the dexamethasone. Could be the patient rapidly metabolizes the dexamethasone, either endogenously or because they're enzyme-inducing agents, or, as in the case I showed you, because the patient has oral estrogen therapy. Now, the metabolism of dexamethasone is a really important consideration here, because if, as we see from this very elegant study performed a few years back now, we give dexamethasone 1 milligram to a whole host of different individuals, the level of dexamethasone in the blood we see at the 9 a.m. blood sample the next morning varies very dramatically depending on the metabolism. So we can see that once it drops below a threshold, there's almost an inflection in the curve. And at this point, the serum cortisol levels are much more likely to be raised because there isn't enough dexamethasone on board to suppress. Oral estrogen therapy, of course, presents a different challenge where we have got an elevated total cortisol level due to the effects on CBG. We can equally get false negative dexamethasone suppression tests if we are a slow metabolizer of dexamethasone in a patient with true Cushing's. So in essence, almost the low dose test, for example, can become effectively the same as a high dose test. Or of course, if the patient has cyclical Cushing's syndrome, so they're in and out of phase. And indeed, we can see really quite dramatically different levels of plasma cortisol after dexamethasone in patients with subsequently confirmed Cushing's disease. So in this patient, not only was the overnight dexamethasone suppression test explainable due to the increase in CBG, due to the presence of the COCP, but in actual fact, when you check with the patient had actually done 2 24-hour urine collections, which unfortunately had been merged. The clue is the very large volume. So this was the UFC output over 48 hours rather than 24 hours. When we went to repeat UFCs, late night salivary cortisol measurements, low-dose dexamethasone without the combined pill on board, and the serum cortisol profile, we can see this patient did not have Cushing's syndrome. So Cushing's syndrome screening test, initial evaluation determined by your index of suspicion of the presence of the condition. Inconclusive initial investigations, think about second-line tests, longitudinal monitoring, and getting a second opinion. Also bear in mind the possibility of cyclical Cushing's, longitudinal monitoring, and timed investigations. So in summary, the majority of our endocrine tests across the patch are relatively easily interpreted and consistent with the clinical picture. However, when unexpected results are encountered, go back to the start. What's the clinical context? Are there any confounding factors or medications? Engage your clinical laboratory team at an early stage. You may avoid unnecessary investigation and inappropriate treatment. Remember, repeating an investigation in another laboratory might not be enough to resolve the problem. They could be using the same or a similarly susceptible platform. And if in doubt, seek expert endocrine advice. There is no shame at all in actually getting the opinion of a colleague, because it may solve the case and it may prevent unnecessary further investigation or treatment. Thank you very much for your attention.